Welcome everybody to the first of Will Norman Nurse webinar on neuroendocrine cancer. So I'd like to just acknowledge the traditional owners of the lands that we're all meeting on and pay our respects to any First Nation people who are present today. So just wanting to go through our participants today. So I'm the host. I'm Meredith Cummins and I'm the CEO for NeuroEndocrine Cancer Australia. I am an oncology nurse by background as well. So our presenters today will be Avril Hull, who is a clinical nurse consultant with NeuroEndocrine Cancer New Zealand. And we've got Kahlia Wolsley, who is the project officer nurse educator with Endocrine Cancer Australia, and Nikie Jervis, who is the Director of Support Services with NeuroEndocrine Cancer UK. And we've got our patient representatives who will be presenting their stories, and we have Siobhan from New Zealand, Jacqueline from Australia, and Lisa from the United Kingdom. And I'd like to acknowledge Novartis as well, who have provided financial support so that we can provide this webinar and also record it for viewing afterwards. So just a few housekeeping parts. The webinar is being recorded, so it will be available to people afterwards. If you can keep your microphones on mute, please, that would be fabulous. If you want to ask any questions, and we're really encouraging you to, because we've got a good amount of time at the end for question and answer, please put it into the question and answer box, not the chat box. And also at the end of it, there will be a pop-up that comes up for a survey at the end so that you can give us an evaluation of how you have found this, this webinar and things that we can do in the future. So I just sort of give you a little bit of information about Will Norman. Will's family lost him to neuroendocrine cancer at the age of 41 in February 2021. And Will leaves behind his wife and 2 children. Working with Will's family, the webinar's been put together in honour of Will, who was a much loved son, brother, husband, father and teacher. And the education of healthcare professionals to increase optimal care and drive earlier diagnosis is an area Will would be very proud to be at the helm of. And as Will was English, we have organised an ongoing liaison with UK and Australian nurses so that we can get these virtual conferences happening, and this is the inaugural conference today. So we're incredibly grateful to Will's family, particularly his father John and sister Jess, for taking the time to get together and for us to learn more about NECA, New Zealand, UK and Australia. Sorry, it should be NeuroEndocrine Cancer UK, New Zealand and Australia, because we're not all NECA. So I will now hand over to Kahlia, and we hope you enjoy the webinar. Please put as many questions in so that we can have a really productive question and answer time, and we hope you enjoy the webinar. Thank you.
Thank you, Meredith. So our first patient rep story is Siobhan from New Zealand.
Hi everyone, my name is Siobhan. I live in New Zealand, and the wonderful Avril Hull has asked me to answer some questions about my diagnosis early on and what went on around then. My story probably is a bit different to most, and I was diagnosed a long time ago. I was 25, which is over 20 plus years now, and it was because I had a family member who was having some gastric issues, went to an endocrinologist and looked into our family history and saw that my father had passed away at 44, and during his lifetime he had had a lot of tumours and organs removed over his whole adult life, and he had never been diagnosed with MEN. It was a long time ago, but he looked at sort of the pattern of what had gone on, including he had had a Whipple for gastrinomas, he had adrenal tumours, and what eventually killed him was either a thymic carcinoid or bronchial carcinoid. We can't actually tell because his chest cavity was just filled with tumours. So this family history meant that we were genetically tested. It took 6 months back then to get a genetic testing result, and out of the 4 siblings, we all were positive for MEN1. So from then on, we would have a raft of tests and scans. And at the time, at the initial diagnosis, I was told I had hyperparathyroidism, and I didn't realise that I was having symptoms for it because they'd come on so slowly. I didn't know that I was unwell. And it wasn't until I had the operation to have all of my parathyroids removed. It was afterwards I felt so much better. I realised I'd been waking up every morning feeling like I was really hungover, even though I wasn't. It's the best way I can describe it. And I just thought that's how everyone woke up because I didn't know any different. So I was grateful to feel better after that surgery eventually. Also, early on in my diagnosis, I was told I had a pancreatic cyst that was coming up on scans, and they kept saying, it's just a cyst, don't worry about it, it'll be fine. However, I was reading and seeking as much information that I could about MEN1 because it was so prevalent in my family, and I've just always wanted to learn as much as I could. And every year when they kept saying it's just a cyst, that didn't sit right with me. I thought this doesn't make sense. When my father had gastronomas, I need to be careful, and I kept asking for it to be investigated further. And it took 6 years, and over that time it grew to the point where it was then 2.6 centimetres, and they decided to go in and take it out. They removed 12 centimetres of my pancreas at the time, and I was just left with the head of my pancreas. And I'm really grateful to have that surgery early on, and I didn't become insulin dependent after losing pancreas, which was great. My remaining pancreas now has nets, but they're stable, and I'm going to hold on to my pancreas as long as I can. I'm enjoying having a stumpy pancreas that's functioning enough to keep me going. So I'm very grateful to know about my diagnosis. I'm very grateful that I've been living all this time really well. And a big part of that, I think, is because I have been seeking information and trying to learn as much as I can about it, because it doesn't just affect me. It actually now affects 8 family members, and we're all doing well, which is great. So in terms of support during those early days, there really wasn't any here in New Zealand anyway. I did reach out to patients overseas. That was the best way that I could find any information, or in particular, I wanted to know about recovering from surgery. That was really important to me. I had 2 little kids at the time, two boys under 5 when I had my pancreatic surgery. So I really wanted to know how quickly I could recover and get back to normal life. And talking to other patients was the best way to find support and information. And that made me realise that we really needed to be able to talk to other patients in New Zealand. When being able to talk to someone nearby, locally, knowing your own health system makes a huge difference, I believe. And I think having access to information is so much easier today. But it's the tricky part now is finding the right information, not being led down the wrong path, and patients, becoming worried about things that don't apply to them. That's probably more the tricky part these days. So I think, if anything, that you could possibly look to share with your patients is, don't hold back on information, because there is a lot out there. So do share what you know as much as you can, and please don't underestimate how much they are willing to learn. They might seem overwhelmed when they're in the appointment with you, but chances are whatever you tell them, they will go away and think about it and do their own research, and I hope, and learn as much as possible, because I think it really does make a big difference. And in particular for my family, if one of us is learning, the whole family is learning, and generations to come. So your time is really valuable, and thank you so much for learning about NETs and taking an interest, because I think they're really interesting and they're a complex disease, and I think they are, I think, you know, patients can live a long time, hopefully. So it's worth investing your time and sharing your knowledge if you can. And again, thank you for taking interest. I really appreciate it. And thank you to Avril, who I think is wonderful. Bye, everyone.
Kia ora from New Zealand. I'm Avril and I work with NeuroEndocrine Cancer New Zealand. I'm going to start off this presentation by talking about what neuroendocrine tumours are, and then talk a little bit about their incidence before Kahlia and Nikie take over. Just like with any other cancer, neuroendocrine cancers develop when cells in the body lose control of their ability to regulate growth. So a neuroendocrine cancer develops when neuroendocrine cells start to grow uncontrollably. However, neuroendocrine cells are a bit special because they're found all over the body, and they're often involved in helping control different organs and how they function through the release of hormones and peptides. For example, in the stomach, they help with the secretion of gastrin to help break down food, or in the bowel, they help with the secretion of serotonin, which helps with gut peristalsis. As a result, neuroendocrine cancers can have many different primary sites for development. Unfortunately, history and the different areas in which they start has led them to being referred to as by different names. Gastrointestinal neuroendocrine tumors, or gastroenteropancreatic neuroendocrine tumors, are the most common, and they can develop in any of these areas: the stomach, duodenum, pancreas, appendix, small bowel, large bowel, and rectum. When neuroendocrine tumors start in endocrine organs, they're often referred to by different names. So, for example, in the thyroid glands, it's often called medullary thyroid carcinoma, or in the adrenal glands, they are referred to as pheochromocytomas or paragangliomas. And again, when they're found in the lung, they're often referred to as carcinoid lung cancers, though I believe this is slowly getting phased out, and they'll just be called lung neuroendocrine tumors. And in the skin, they're called Merkel cell carcinomas. So lots of different names, which can be quite confusing and overwhelming for our patients. Moving on to the incidence of neuroendocrine tumors. Neuroendocrine tumors are often referred to as rare. However, internationally, reports indicate that incidence and prevalence is definitely increasing, particularly over the last 30 years. This could be due to scanning and diagnostic techniques improving, or due to an increased awareness of this cancer type, that it's no longer being classed incorrectly as a lung or a bowel cancer. Internationally, the average age of onset is usually between 50 to 60 years of age. However, they are found in all age groups, right from childhood, and incidence increases with age. This slide shows a breakdown of the 3 nations presenting today. So the incidence, we can see in New Zealand, we've just got a very small population in comparison to Australia and the UK. But one thing it highlights significantly to me is that after diagnosis, there are many people still living with this cancer. And so obviously they can live with this for quite some time, which I'm sure Kahlia and Nikie will cover shortly. This table looks at the incidence of neuroendocrine tumors by their primary site. 2/3 of all neuroendocrine tumors are those gastroenteropancreatic neuroendocrine tumors. The other 1/3 are mainly bronchopulmonary neuroendocrine tumors, with small numbers in other sites. If we look within the GEP-NETs, or the gastroenteropancreatic neuroendocrine tumors, almost half of these tend to be small bowel neuroendocrine tumors, And then if we look at this final column in this table, it looks at the overall survival rates at 5 years. Prognosis of neuroendocrine tumors is associated with their location, their functional status, the differentiation, and the initial stages. In advanced stages, obviously prognosis is poorer. However, the overall survival of well-differentiated neuroendocrine tumors and localized neuroendocrine tumors does tend to be much longer. You can see from this that the best overall survival rates are in appendiceal and rectal nets, with over 90% at 5 years. The majority of nets are not hereditary. Approximately 10% of all neuroendocrine tumors are linked to inherited genetic mutations or syndromes. However, this percentage can vary depending on the specific type of net, with some like pheochromocytomas and paragangliomas having a higher proportion of hereditary cases. NETs can be associated with genetic syndromes such as multiple endocrine neoplasms, MEN, and von Hippel-Lindau syndrome and neurofibromatosis. This table shows some hereditary tumor syndromes and their known association with neuroendocrine tumors. The most prevalent syndromes are MEN1 and von Hippel-Lindau syndrome. Pancreatic neuroendocrine tumors may develop in 35 to 75% of patients with MEN type 1, and they tend to be much younger at diagnosis, like Siobhan's story. People with known von Hippel-Lindau syndrome have a 5 to 10% chance, of developing a PNET and up to a 20% chance of developing a pheochromocytoma. The incidence of neuroendocrine tumors occurring in men and women is fairly equal, with a slightly higher incidence of small intestinal, pancreatic, and rectal nets occurring in men, and a slightly higher reported incidence of lung or bronchopulmonary nets, appendiceal nets, and adrenal nets occurring in women. According to the SEERS database, there are some differences in the incidence of neuroendocrine tumors in different population groups. Like, for example, appendiceal nets are more prominent in white populations. Small bowel neuroendocrine tumors and PNETs are more common in African American and Asian populations. The incidence of rectal nets is 3 times higher in Asian populations than non-Asian populations, and also has a higher prevalence in Black populations than white populations. Geographically, obviously different countries have different statistics as well, and there's one of significance probably with difference between the UK and Australia and New Zealand, in that the incidence of Merkel cell carcinomas is known to be much higher in this end of the world, the Southern Hemisphere, Australia and New Zealand, than the UK, because of the known links with sun damage to the skin. I hope this gives just a small insight into the incidence of neuroendocrine tumors, which obviously varies within each country further. Thank you.
Thanks, Avril, for that wonderful presentation. So now we have patient rep Jacqueline, who'll be telling her story, and she's from Australia.
Hello, I'm Jacqueline Gillespie, and I live in Sydney, Australia. I live in a town in the inner city of Sydney, in a place called Annandale, and I live on Gadigal land. I'm 64, and I was diagnosed with NETs in 2016. My NETs is primarily probably on the small bowel. They're not sure, but when I was diagnosed, it metastasized to my liver and also to some bone areas. I live here with my partner of 30 years and my 2 schnauzers, who have interrupted this recording several times. You can see them there. My journey to diagnosis is probably very similar to others in that it took a long time. So probably at least 7 years before I got my correct diagnosis. And that journey was most likely impacted by two things. I was menopausal, so going through menopause, and many of the symptoms are like, or could be put down to menopause, which is a problem for women my age with this disease. And secondly, I was living overseas as an expat. I was based in, my partner and I were based in Singapore, and I had a very big job, and I was traveling extensively around the region. And I put a lot of the symptoms also down to potential stress, working very hard, tiredness, and so on, because of my job. And I wasn't really paying attention to my body so much. I was more interested in what I was doing with my work. The symptoms that I had leading up to my diagnosis kind of were symptoms that escalated over time. So I started with things like a lot of heart palpitations, some gut issues, and what happened when I was living overseas was when they were acute, I'd often end up in a hospital somewhere else other than Singapore. So I had some issues in China, in Shanghai, and ended up in hospital there, and they thought it was linked to cardiac arrhythmia. I was in Malacca and had a similar experience, but very dizzy and weak, and also put down to heart issues. I was traveling to the Philippines, and I had this massive skin outbreak and irritation, and that was just put down to like allergic reactions to something. I had very bad diarrhea after a trip to India, and in Singapore, that was put down to diarrhea rather than, gut issues linked to the cancer. And so, there was lots of symptoms going on, but nobody was putting the full story together, and I wasn't either. We decided to come home in 2014, and it was still another 2 years after being back home here in Sydney that I finally got my diagnosis. What led to that diagnosis was firstly, an escalation of all of those things, plus just complete fatigue. And also I started to experience great pain in my liver gut area. I just went to my GP and said, look, something's terribly wrong. And I was sent, the GP was on leave, and I had a fabulous registrar who felt around my gut, felt some lumps, and sent me off for an ultrasound. And, I had my ultrasound. During the ultrasound, the radiographer said, there's a problem, I need to get the doctor. And then everything started from there. So you can imagine it was quite shocking and frightening. The way in which I got my diagnosis in the end was through blood tests, scans, several scans, colonoscopy. And the specialist said, look, you've got cancer in your liver. It could be liver cancer, or it could be this other cancer called neuroendocrine cancer. And the only way we can decide, tell is through a liver biopsy. So I had a liver biopsy, and then I got a call on my birthday, actually, to tell me the good news that it wasn't liver cancer, but it was neuroendocrine cancer. So obviously that was shocking. I had never heard of neuroendocrine cancer, so I had no idea what it was, never heard of it, didn't know what was going to happen, whether it was curable. So that was quite a shock for me. So you can see along the way I got diagnosed with many things: irritable bowel syndrome, cardio, arrhythmia, I also was sent to a psychologist because I had all this breathlessness and it was put down to anxiety. I saw many doctors, both overseas and back here in Australia. And so it was a very confusing journey. Just all I knew was I just didn't feel right and it was getting worse. The support I got, once I got my diagnosis, I was put into a kind of a slipstream of, you know, an oncologist who wasn't a specialist in NETs, but did deal with NETs. And then I realised after a bit of research, and he actually put me in touch with NeuroEndocrine Cancer Australia. And after some research and hearing other patients' stories, that I needed to get to a specialist, a Centre of Excellence, which I did. And I now have a multidisciplinary team that looks after me out of Royal North Shore. And I feel really, really supported by that kind of group of specialists. But, you know, up until that point, it was really hard work. The other thing I think that was really hard is that, you know, a lot of patients with this disease don't look unwell. We look well, but we're not well. And so all the symptoms can be not put down to cancer. And also it affects people of many age groups. So instead of, you know, a classic older person with cancer, you know, I was 55 when all of this was going on. So, and I looked okay, even though I wasn't okay. So that was my journey to diagnosis. The support through all of that has come from many sources. And of course, what has happened is I've now had lots and lots of treatments. And the treatments have included, I've had a TACE, I've had 2 CERTs, I've had 2 PRRTs, I have monthly injections and quarterly injections, and I'm scanned every quarter. So I've had to interact with the medical system a lot. And there are lots of side effects of all of that work, from the treatments to the scanning process and so on. And this is where I think the role of nurses and nurse coordinators and RNs has played, for me anyway, a really important role. What I found is that you people, nurses, have a lot of information to share, and particularly around the symptoms that occur when you're going through the treatments. I have a couple of nurses at the nuclear medicine area at Royal North Shore that know me very intimately, know me by name, and know all my quirks and all the problems that I have when I have my treatments. And their knowledge has been absolutely appreciated, so much appreciated by me. Things like cannula insertions, which seem small but become major when your veins are quite damaged by all the scanning process. Knowledge about blood pressure. I have low blood pressure and how to manage that effectively during treatment and during the scans. Knowledge about diarrhea, constipation, the system and how to kind of manage the system, and just genuine caring that is given to me, I really, really appreciate. And when it doesn't happen, I can notice it a great deal. It makes a huge difference to my experience. And so the other thing that I've appreciated from the nurses has been their accumulated knowledge from other patients and what they've seen work and not work in terms of the treatments, and also all the symptoms that come with that. And so if I was to suggest, you know, one, the question here is, you know, what's one suggestion to take away from my story, is that, you know, educating yourselves around this disease and the symptoms associated with that disease, and putting together the symptoms into a story, and not making assumptions about the patient and the patient's kind of level of fear, anxiety, but meeting them where they are and being really willing to share everything you know, because all of that information becomes valuable, highly valuable to patients like me. So I hope my story's been useful to you, and I'd just like to say thank you for everything you do. It's highly valued. And enjoy the course.
Hello, so my name is Kahlia. I am the Project Officer and Nurse Educator for NeuroEndocrine Cancer Australia. So my two topics I'll be covering are symptoms and diagnosis, as well as touching on the difficulties our patients and healthcare professionals face when diagnosing NETs. So during her presentation, Avril explained that neuroendocrine cells have this unique ability to act as hormone secretors. Because of this unique feature, neuroendocrine cancers can then be further classified based on the hormone secretion as either being functioning or a non-functioning NET. So a functioning NET is characterized by their ability to produce excessive hormones. The hormones produced by functional NETs can lead to a variety of symptoms, often dependent on the type of hormone being overproduced. Non-functional NETs do not produce excessive hormones that result in recognizable symptoms. Instead, their impact is often related to the size and the location of the tumor. This lovely table is a snapshot from NeuroEndocrine Cancer New Zealand, a guide for patients, which shows different functioning NET syndromes and side effects. Please note that this image has been cropped and does not display the full spectrum of functioning NET syndromes. It includes only a selection just to give you an idea of the variety of symptoms that can occur depending on the hormone being produced. So first off, we have carcinoid syndrome, the most common functioning syndrome, which is caused by the hormone serotonin. Symptoms include your flushing, wheezing, diarrhea, and carcinoid heart disease. Other less common functioning NETs are your insulinomas that produce the hormone insulin. So symptoms include your traditional hypoglycemia symptoms, confusion, sweating, weakness, and in some cases, unconsciousness. Next, we have your gastronomas with the hormone gastrin. So symptoms may be your esophagitis, your peptic ulcers, your reflux, and your diarrhea. You have vipoma, you've got your peptide hormone VIP, so your vasoactive intestinal polypeptide, but this can cause symptoms such as your watery diarrhea, your weight loss, your nausea, vomiting, fatigue, and weakness. Gluconoma associated with the hormone glucagon, which can cause your skin rashes, unexplained weight loss, hyperglycemia symptoms, mouth ulcers, and diarrhea. And lastly on the graph is your somatostatinoma. So the hormone here is somatostatin, and symptoms for this is your gallstones, weight loss, diarrhea, fatty stools, and your hyperglycemia symptoms. I'd like to take a moment just to reflect back on Jacqueline's story and touch on some of the symptoms she experienced. So Jacqueline shared that over time, she presented to hospitals and healthcare professionals around the world with a range of symptoms, including heart palpitations, dizziness and weakness, skin outbreaks and irritations, had diarrhea, fatigue, as well as some abdo pain. It wasn't until these last few symptoms escalated that Jacqueline finally got her correct diagnosis. So as we've discussed with functioning NETs and seen firsthand with our patients, due to there being so many different sites in the body neuroendocrine cancer can occur and potential hormones they can produce, it means symptoms and the experience of each person with NETs can be quite varied. The most common symptoms seen, however, are shown on the screen. As you can see, they're commonly non-specific. They mimic those of other more common diagnoses and often leading to misdiagnosis, as you've just seen with Jacqueline. The wheel in the top right-hand corner of the screen also gives you some examples of how these symptoms can be misinterpreted and lead to misdiagnosis. For example, diarrhea, misdiagnosed as irritable bowel syndrome, flushing thought as menopause, and wheezing as asthma. So at what point do GPs and healthcare professionals start suspecting, could this be a NET? We educate that it should be suspected if they have a combination of these symptoms or persistent symptoms despite the usual treatment regime. So moving on to diagnosis, NECA, the International NeuroEndocrine Cancer Alliance, did a survey in 2019 looking at the challenges in access to diagnostic and treatment for NET patients. NECA is relaunching this global survey again this year, so stay tuned. However, at this point, I do only have the stats from 2019 survey, but it's still really interesting to see the difficulties and experience the patients have and are facing. So 27% were correctly diagnosed immediately, 44% were misdiagnosed for several years, 26% received their diagnosis incidentally, and on average, it takes 5 years from the initial symptoms for an accurate diagnosis. 60% of patients are at stage 4 by the time they are diagnosed. Back to our lovely patient Jacqueline and what her diagnosis looked like. So Jacqueline, who was initially misdiagnosed with irritable bowel syndrome, cardiac arrhythmias, and anxiety. It took 7 years for Jacqueline to get a correct diagnosis. And tests that were undertaken to get to this point included your ultrasounds, your blood tests, scans, and a colonoscopy. So this screenshot shows timeframes for care and is from the Australian Optimal Care Pathway. So symptoms we have covered. Next is the initial investigation. So where there is a strong suspicion of NETs, investigation should be conducted within 2 weeks of the initial GP appointment. When a patient presents to their GP with suspected neuroendocrine cancer, initial investigations should include a thorough medical history and a physical examination. Baseline biochemistry and structural imaging should be undertaken depending on the symptoms and the site of the suspected tumour. Following these initial investigations, it is essential that any patient with a suspected or confirmed neuroendocrine tumour should be referred to the appropriate specialists, such as your medical oncologist, your respiratory physician, your gastroenterologist, or your endocrinologist, within 1 week of completing these initial investigations. Diagnostic investigations for neuroendocrine cancers should be ideally be completed within 2 weeks of the initial specialist appointment. So these investigations may include your biochemical markers, your imaging, and your histopath confirmation. So in terms of biochemical testing, your chromogranin A or your CGA remains the most established biomarker at this stage. It's a simple blood test and it measures the glycoprotein secreted by the neuroendocrine cells, and it can provide valuable diagnostic information. However, clinicians must be aware of its limitations. So false positives may occur in the setting of reduced renal function, atrophic gastritis, your liver disease, cardiac failure, inflammatory bowel disease, or in some patients taking some medications, for example, your proton pump inhibitors. For this reason, CGA should always be interpreted with caution and used in conjunction with imaging. It's also important to note that CGA testing is not currently available in Australia, and therefore incurs an out-of-pocket cost for our patients. Another key biomarker is the urinary 5-HIAA. So this measures the breakdown product of serotonin in the urine. So this test is highly specific in serotonin-producing tumours, particularly your classical midgut tumours, and it can also be used to assess the risk for carcinoid syndrome and carcinoid heart disease. However, again, when having these tests, patients' education is needed as a number of foods and medications can interfere. So some foods with like your tryptophan-rich foods, such as your bananas, pineapples, avocados, and walnuts, just to name a few. So again, both CGA and 5-HIAA are valuable tools, but they should be used cautiously, especially in the pre-diagnostic phase, given the potential for false positive. Imaging is another cornerstone of diagnosis. So you've got your anatomical imaging, for example, your CT or your MRI, and then your functional imaging as indicated. So these ones are your gallium-68 dotatate scan, which is particularly valuable for detecting your somatostatin receptor expressing well-differentiated NETs, and it also provides a theranostic assessment that can guide suitability for radionuclide therapy as well. Your FDG scan, alternatively, is more informative in cases of high-grade, poorly differentiated disease, where uptake reflects increased metabolic activity. Finally, histopath confirmation remains essential. Tissue diagnosis, whether through biopsy or resection, is critical during diagnosis and to establish tumour grade and differentiation. Whenever possible, these specimens should be reviewed by a pathologist with expertise in neuroendocrine cancer. As previously mentioned, in Australia, we have an optimal care pathway for 30-odd cancer types, which describes the standard of care that should be available to all cancer patients treated in Australia. So the pathways support patients and carers, health systems, health professional services, and they also encourage consistent optimal treatment and supportive care at each stage of a patient's journey. For neuroendocrine cancer, we have a patient resource, the Guide to Best Cancer Care. So this is a simplified, the optimal care pathway, and it covers items like timeframes to expect tests, what might happen at different steps within their NET journey, and questions to ask the treatment team to ensure the best care they can get. We also have a quick reference guide for healthcare professionals, which summarises the optimal care pathway for health professionals and health services. It includes optimal timeframes within which tests or procedures should be completed, a checklist with indicators and related to recommendations within the optimal care pathway. And then we have the full optimal care pathway guide. So this optimal care pathway is intended for health professionals and services, but it also helps patients and carers understand their care process if they want to look at it and review it. Its aim is to support health professionals in delivering evidence-based, timely and coordinated cancer care. It promotes clear communication and collaboration with patients, families and between providers. It guides new professionals entering the cancer care workforce and also helps identify service gaps and drives quality improvements in the cancer care system. For those in New Zealand, there are resources readily available once diagnosed, similar with Australia and UK. In UK, they have slightly different resources to assist with awareness and diagnosis. So these are practical guides, a series of neuroendocrine cancer overviews for healthcare professionals, from your GPs, your endocrinologists, gastroenterologists, your surgeon, oncologists, and healthcare professionals. So these act as bite-sized practical education, giving an overview of neuroendocrine cancer, including its definition, key facts, clinical presentations, and signs that may indicate NETs. In 2024, a patient care pathway was published in the Journal of Neuroendocrinology. So this pathway is structured in line with NHS Constitution for England, and it's informed by current literature and extensive consultations with multidisciplinary experts. So this pathway outlines the key phases of care through the beginning of initial suspicion, extending through to diagnosis, treatment and follow-up. Its purpose is to guide consistent disease management and to address the barriers to care that are frequently encountered within the NET community. And that it concludes my part of the presentation. Thank you very much. Before I introduce our next patient rep, I just want to remind everyone that we do have a Q&A button at the bottom of your screen. So please pop in any questions that are popping into your mind at the moment, and we will be sure to get to them when we do our Q&A at the end. So our next patient rep is from the UK, and her name is Lisa, and we're just about to listen to her story.
Hello everyone, my name is Lisa Webb. I am a 51-year-old mother of two who is living currently in Leeds in the UK. I'm originally from Ireland, and my journey with NET started in Ireland, I suppose. So my diagnosis is that I have a lung NET, an atypical lung NET, which there's a long history with it really. So I think the first symptom that I had, I was 35 and had become quite breathless and noticed that I had a cough that wouldn't go away. And I went to see my doctor, but I'd been diagnosed with asthma at 19, and it was felt that this was a recurrence of asthma really. And I was put on an asthma plan that didn't do anything at all for the symptoms. And that started a process of going back and forward to doctors on a regular basis, trying to get to the bottom of what was going on. Unfortunately, I suppose my experience with the medical profession at that time wasn't great. And I'm happy to say that in later years it did get a lot better. But in those early days, I felt like I just wasn't heard. I wasn't listened to. And a lot of times I think the onus was put back on me in terms of not following asthma plans accordingly. And anyone who knows me knows I'm a stickler for rules. So when I'm given a plan, I will stick to it quite rigidly. So going back and forward to the GP for a while, I was put in touch with the asthma nurses, and there was a variation really of responses from asthma nurses at that time. There's quite a high turnover in our surgery, so I never really got to build a relationship with one particular nurse, which I often look back and think was part of the missing piece really. So I was seeing different nurses at different times, being put on increasingly heavier inhalers, and nothing was working. The other thing was that I was really quite fit and healthy at that time outside of these symptoms. So I was running at that point. I was in the gym every morning, quite fit and healthy, looked after myself, had a great diet, and felt really good outside of this. So when I was constantly being told it's just asthma, I suppose I just learned to live with it. And going back and forward to be told, you need to do this better, you need to, perfect your technique with your inhalers. I really did feel that it was something that I was doing wrong. And I think I just internalized that and moved on with my life and continued to just try to live with these symptoms. So fast forward a few years, coming up to the COVID pandemic in 2020, things were getting a lot worse. And I started to have this real issue about lying on my left side, and I couldn't catch my breath at all. So it felt like there was a blockage there, and I went back to the doctors and was saying, I can't lie on my left side, I can't breathe, this is really quite strange. And the response I got from every medical profession was a head scratch, just not quite sure what this is about. It doesn't seem to make sense and doesn't fit with the asthma. But nothing really further was done. There was no follow-up. I do remember one locum doctor one time, she'd give me a good sounding out in my chest, and she said, you don't have asthma, your airways are clear. But she sent me for a heart scan instead, because I also have a heart murmur, so it was quite loud, and sent her on the wrong path, I think, in terms of she knew something needed to be looked at, but unfortunately we went on the wrong path. So when the heart scan came back clear, again, it was a case of, well, we don't know, basically, stick with your asthma plan. So I moved to England. This all occurred back in Ireland. I moved to England for work in 2021. And the first thing I did was register with the GP and make an appointment to see the asthma nurse, because I was struggling now. It was COVID. I was really anxious about being able to breathe in the middle of this pandemic. And the asthma nurse here in England, she was just fantastic. She really listened when I was saying something doesn't feel right, something's getting worse. I do these things, I follow these plans, nothing's helping. And she put me on another asthma plan, but monitored it quite closely. And within 6 months of back and forward, she said, I'm not happy, I'm going to send you for an x-ray. So she sent me for an x-ray, which was quickly followed up by a CT scan, and then the diagnosis came quite out of the blue then in December 2021. And I do always remember going into the hospital for the diagnosis. Cancer was not on my radar. I'd suffered with these symptoms for so long. I thought if it was cancer, I'd be dead by now. My only understanding of cancer was that it was quite deadly, and I wouldn't survive that length of time with cancer in my lung. So I went to the appointment on my own. I didn't. My husband had wanted to come with me. I told him not to bother. I thought I was going to go to be told I had COPD, which runs in my family. But so the diagnosis was a complete shock, absolutely a complete shock. And again, it was the nurse. The doctor gave me the diagnosis. I was in total shock and really had a bit of a meltdown. And it was the nurse who came in and took me into a side room and spent some time with me, reassuring me. It was all a blur at that stage, but I do remember quite clearly some of the things that she said to me. Firstly, she held my hand, which really helped center me, just brought me right back into the room. And she just kept rubbing my hand and saying to me, "We've caught it early, don't worry." and I remember thinking, I've had these symptoms for years, this is not early. But she was saying it's early enough, we can treat it, things are going to be okay, you know. So she was very good helping to support me there. Then there were a fantastic set of lung specialist nurses who tried to support me in the best way they could, but they had limited knowledge, I think, of neuroendocrine tumours. You know, their speciality was lung, and this was a neuroendocrine tumour, so there was quite a difference in what they could do and how they could support me. So unfortunately, I had to lose a complete lung because of the position of the tumour. I had to go in for the pneumonectomy. It was done during COVID. I had to go into hospital on my own, spend 8 days in hospital without visitors. You know, a really trying time. And again, I remember 1 or 2 nurses who were just fantastic and being, you know, human, really, being able to take time in the middle of a very busy shift to listen to you and, you know, just support me really through a very, very difficult time. So in terms of the afterwards, then the recovery period, I was told at diagnosis it was a typical lung net. It turned out then in the histopathology that it was an atypical lung net. I had sort of really researched neuroendocrine cancer during that time, and I became aware that, you know, as a result of it being atypical and that I had lymph node involvement, that this was a significantly different situation from a typical net. But again, I found that in the medical profession that wasn't really well understood, and I was offered a treatment plan that was no different from the typical lung net treatment plan. So I had to advocate for myself. I had to work quite hard to find a specialist, a neuroendocrine specialist in Manchester, which is quite a distance from where I live in Leeds. But I travelled there to the Christie in Manchester, and Professor Mansour agreed to take me on as a patient. And from that moment, everything has just fallen into place because I've got people who really understand this disease and who can reassure me in the darkest of moments when I'm panicking about every little symptom, that, you know, things are okay, that they know this disease and they can understand it. So I think really in terms of my journey with the medical profession throughout this really difficult period, it's been hit and miss. I often feel quite aggrieved actually about the early years and how I wasn't listened to. And I often wonder if I'd been listened to earlier before the tumour grew in any great size. Could I have saved my lung? You know, would something have happened where I wouldn't have had to lose a lung, because it's quite an impactful thing in life. So I don't know is the answer to that. I'm not quite sure, but the feelings of being unheard, unlistened to, this hierarchical structure that can get going within the medical profession sometimes, where you feel you can't question, you can't push. It was all very difficult and led to a situation where I was left for very many years with symptoms that I shouldn't have been left with. On the flip side of that, the good medical professionals I've come across who take time and listen and really understand, not in terms of symptoms that fit in a box, but how this disease is hitting me personally, how I'm experiencing it, what my symptoms are. You know, back in the day, I was a 45-year-old woman who was running, was in the gym and looking after myself, and was quite easily dismissed then in terms of, you know, you're fine, you're fit, you're healthy. But if someone had taken time to listen to, I can't breathe on my left side, this is not normal, and just sent me for an x-ray, You know, things could have been so much different. So I suppose my key note really to any nurses that come into contact with patients that don't fit quite neatly in a box, please listen. You know, just please listen to their experience, what they're telling you about how their body feels. Because what I've come to learn is that I'm the expert of my body, I'm the expert of what goes on inside me, and I can communicate that quite clearly. The issue is whether people are willing to listen or not. But I'm really grateful to the medical profession that have got me where I am. You know, I'm still alive and kicking. I'm going to be a grandmother next year. I'm delighted to get to the point in life where I can really sit back, look at a traumatic experience and say, I'm okay. You know, that there are people that are looking after me. And I wish that for every NET patient really that comes into contact with medical professionals. So please listen, please take on board the patient's experience and ask questions when things don't look right. Thank you.
Okay, we're on the home stretch now, and only the last few slides to go, so stick with me. Over the next few slides, we're going to review the grading and staging for neuroendocrine cancers, before a brief overview of treatments. And what I hope to do is maybe dispel a few misconceptions about this group of cancers, the biggest of all being that all neuroendocrine cancers are slow growing. We've come a long way since 1907, when these cancers were described as being cancer-like rather than true cancer. But it wasn't until 2017 when the World Health Organization stated that all neuroendocrine cancers should be considered as having malignant potential, not benign, and defined two key classifications: neuroendocrine tumours and neuroendocrine carcinomas. However, in neuroendocrine cancers of the lungs, terminology has yet to completely align with other primary sites and retains the somewhat archaic term of carcinoid when describing lung neuroendocrine tumours. So what do we mean by grading? Grading is about proliferation, quite simply the rate at which abnormal neuroendocrine cells divide and grow. Ki-67 is the most commonly used measurement, making use of the ability to sustain protein released by proliferating cells to assess how many there are. Mitotic rate is simply counting the number of cells in visible stage of mitosis in a specified area. Using Ki-67, nets are most commonly graded 1 to 3. The higher the Ki-67, the higher the grade, the more aggressively the tumours may behave. While many nets fall into the grade 1 to 2 range, an increasing number are being identified as grade 3, but exact data is difficult to collect as coding is still yet to catch up. In lung nets, mitotic rate is still being seen as more reliable than Ki-67, possibly due to some additional histopathological factors. However, where it may be helpful is in determining between high-grade atypical carcinoids and the lower end of neuroendocrine carcinomas. The difference between neuroendocrine tumours and neuroendocrine carcinomas is extremely important, especially in terms of treatment options and prognosis. A low-grade, high-stage neuroendocrine tumour may well have a much more positive outcome than a low-stage but high-grade neuroendocrine carcinoma. Too often, stage 4 disease is seen by many as the life-limiting factor, but grading can be as important. Staging essentially tells us more about the burden of disease, including whether it's infiltrated locally or spread further. The most common system used to determine stage is the TNM system, tumour, nodes, metastases, which can be assessed by either radiology or histopathology, and the stages here most commonly used are outlined. Please note that in some primary sites, a different staging system may be used. For example, in gynecology, they use the FIGO system, but I won't go into that here. In summary, it is both grade and yes stage that can help determine treatment options and prognosis. So what are the options and how do they differ? Of vital importance in decision-making around treatments for neuroendocrine cancers is the involvement of an expert and experienced specialist MDT, and that is a disease-specific MDT, not a generalist. Even if the patient is not physically seen at a centre or by a specialist team locally, it is important they are linked in so that they benefit from the knowledge and experience of the specialist team. In the UK, we don't have quite the same geographical distances to consider, but we do have issues with expedient access to expertise, and that can be as problematic. So around treatments, it's usually founded on 3 principles, but before we go into those, it's also important to acknowledge the role of watch and wait. In some cases, once diagnosis is confirmed, surveillance alone can be the most appropriate management strategy, especially in low-grade, small sub-centimetre, asymptomatic primary site disease. So let's go on to the 3 principles. The 3 principles are around: can we remove it safely? Do we need to treat symptoms either before or alongside anti-proliferation treatment? So in terms of surgery, can we take it all out without causing more harm than good? Is there benefit in debulking, in reducing the burden of disease without causing longer term consequences? And do we need to bypass a problem? So for example, in bowel obstruction, where we may not be able to remove the tumour, but we may be able to reduce the complication of obstruction. In symptom therapy, are we talking about the mass effect, the actual presence of the tumour, or about its potential to release excess hormones and therefore need to address those first? And also paraneoplastic. It's a rare consequence of having cancer, any cancer, but it may also be the presenting sign and may well need to be treated. For example, in lung nets, a small percentage may present with Cushing's, and that may need to be addressed before we can think about treating the tumour itself. And then anti-proliferative therapy. What can we do to control the tumour or to reduce it? Many therapies have both anti-proliferative and symptomatic effects, but the provision of holistic psychosocial and informational support throughout is absolutely essential. This slide lists some of the treatments currently available. However, not all treatments will be suitable or be effective across all types, and not all treatments will be available for all types. For example, in the UK, where there is evidence that PRRT, or lutetium efficacy, in both lung nets and pheoparagangliomas, it is not NICE approved, and therefore not available on the NHS in England for those particular indications. We'll talk more and explore more about treatments in our next webinar, but for now the last word goes to the most important people here in the webinar, Siobhan, Jacqueline and Lisa, and their take-home messages. Thank you.
Thank you, Nikie. So as Nikie mentioned, so the final words from Siobhan, Jacqueline and Lisa, the messages that they would like you to take home from this webinar and their stories. So Siobhan, share with your patients, don't hold back on the information. Share what you know with as much as you can. Don't underestimate how much patients are wanting to learn. And if one person is learning, then the whole family is learning and generations to come. Jacqueline's take-home message, so educating yourself around neuroendocrine cancer and the symptoms associated with this disease and putting these symptoms into a story. Not making assumptions about the patient, their level of fear and anxiety, but meeting them where they are. And be willing to share everything you know, as this information becomes valuable to patients. And Lisa's take-home message is, if you have someone that doesn't quite fit neatly in that diagnosis box, listen, take on board the patient's experience and ask the right questions when things don't look right. And listen, please just listen. So we'll now be moving on to our Q&A, and Meredith will be hosting this Q&A.
Thanks, Kahlia, and thanks so much to all our nurse representatives and also for our patients putting those stories forward. Still want to urge you to put any questions that you want to ask. They can be very simple or, you know, more complex if you feel like you want to ask something like that, but there is no silly question. I was going to ask the panelists what their survival rates are, survival rate, end of the day, for UK and New Z. And we've, I know in Australia it's around about 51% for 5 years. But we've had a quick sort of look because New Zealand haven't got it very well documented with their registries or anything, and the UK, they've both come back with sort of varying between sort of around about 30-40% to 90% as far as their 5-year survival rate. Pretty similar to the SEER data that was presented by Avril, which is the US. So it's very interesting as far as the survival rates and everything, because if it's a lower grade, it's going to be sort of the survival rates are a lot higher. Whereas if it's an aggressive grade 3 neuroendocrine tumour or grade 3 neuroendocrine carcinoma, it's a lot more aggressive, so the survival rate is a lot less. So I'm going to open this up to each of our panelists and ask just what advice you would give to patients who are not yet or newly diagnosed. So I'm happy to hand that over to, well, Avril to start off with.
So what information we give to patients when they're first diagnosed, it's usually just around giving them the basics, trying to understand their cancer and understand what they understand about their cancer, and then providing as much reassurance as possible. And then just slowly adding in a little bit about how fast it might be growing and giving them that education around that. Because quite often, as we heard from some of our patients this evening, the word cancer is like a death sentence. And they automatically assume that, you know, it's just crushes their world. So giving them a little bit of information about how fast nets can be growing, and usually they tend to be on the slower end. It almost empowers them to seek a little bit more information before moving on to all the intricacies around treatments and things. Because I think we don't always jump into treatments very quickly with neuroendocrine tumours. And so providing that reassurance on how fast they're growing is key to reassurance for not jumping into treatments.
Excellent. Nikie?
Yeah, I agree with a lot of what Avril has said, but I think, you know, your question was if they suspect or newly diagnosed. I think as each of our patients have said, you know, unfortunately there is this reliance on this self-advocacy, this pushing, this not accepting, that knowing your body, and actually, you know, is about continuing to challenge if which can be really difficult when you're not feeling that well or when you're not feeling listened to. It is finding the resource and support. I think organisations, I would say this obviously, but organisations such as ours can help that. And I think that one of the things that Siobhan said was that reaching out and speaking to others, not only does that help inform you, but it also helps build your confidence in being able to take things further. I think the difficulty we have in the UK is there is no optimal care pathway. We've suggested one, it's yet to be implemented. So even if they do get a receptive GP, that GP has struggled to know where to refer on to because there is no pathway. So I think that getting the knowledge, this why information is so important. It is following through and finding your support. And that puts a huge burden on the individual. But until we get improvement in access and improved knowledge on the medical side, it's going to continue to be difficult.
Thanks, Nikie. And Kahlia.
So at NeuroEndocrine Cancer Australia, we have lots of supportive resources for patients, especially during the diagnosis and during throughout their cancer, but also pre-diagnosis. So as mentioned in my presentation, we have an optimal care pathway quick reference guide that our patients can take to their GP just to help to advocate for their symptoms, what they're suspecting they may have as well. And we also do have a questions fact sheet as well, which can help with those questions, especially when they're feeling nervous or overwhelmed and anxious when they're going to these appointments. So there is multiple resources there, and these support groups that we have, the Net Nurses Online, please get your patients to call, because we're there to support them throughout the pre-diagnosis journey as well.
If I can just come back to that, I think that the fact is we also have similar resources here in the UK, but it's whether somebody knows where to find that resource. Yeah. And if they don't know about it, so many times we're contacted, we're actually told that it was purely through their own Google researching that they found us.
Yeah, exactly. That's why having these webinars and sharing about what we can offer and what we have and about neuroendocrine cancer is so important, because you guys are the face running, seeing these patients, and being able to let them know that we are here to support them and you guys is very important.
Yeah. So we've got a question on the Q&A that what advice would you give to nurses who are new in their post as a neuroendocrine clinical nurse specialist? And I'll open that up to whoever would like to answer the question.
If you're in the UK, if you're in the UK, and it may be helpful to those outside of the UK as well, we did some work and we've put together a Royal College of Nursing accredited nurse competency framework that outlines and gives sort of a direction, a framework of building knowledge, and it's sort of timed to your own personal development as well, and that's available through our website. And we are also developing, we had an academy, and that is being reviewed and that is being updated, so there are formal modules that will be available. I think reaching out, using your professional networks, the professional societies, UKNETs here in the UK, but also ENETs have a nurse group, and it's where you can actually buddy up maybe and have some direction, but talk to each other. It can be very isolating if you're the only CNS in that position. I know quite well, both Kathy and myself. Kathy, who co-founded the charity, was the first NET nurse in the UK back many years ago, and I'd started with NETs named as part of my job. So learn from your peers and reach out. We're here, we're available, and happy to sort of help.
I can add that I was the first NET nurse in New Zealand, and it was overwhelming and terribly scary, especially when I was introduced by the consultants that I worked alongside as the nurse specialist. And I was thinking, oh my gosh, I don't know anything yet. Give me a break. I'm still learning. But as Nikie said, I reached out to all the NET centres around the world and just said, help, I'm new to this, send me all your information. And everyone was really welcoming and really supportive. So yes, as Nikie said, reach out to all the organisations that you can and get that information. We're all, all eager to help and learn and support as many people who are interested in NETs to learn about NETs, because it makes a huge difference to our patient populations.
And in Australia, we have healthcare professional modules as well. So if you have an AHPRA number, you can register. You get 10 CPD points, and it's a great resource to learn more about neuroendocrine cancer. So if you're from Australia, then I'd highly recommend that. What else have we got? Just trying to think, or just reaching out even to the net nurses online. So calling our 1300 number will really, like, the nurses are there to help support you as well. So if you've got any questions at all, reach out. We're there to help as well.
Actually, I should just add, we in New Zealand have access to that healthcare professional course that's run through Australia. So, yeah.
Lovely, thank you. And we've got another question. Is there a list of experts in NETs around Australia? I'm in Tasmania and often my patients may move interstate but still choose to come back to Hobart for screening and care because of our expert doctors. If there was information about other expert doctors, they may choose to transfer their care. So I think must be Kahlia is the one to answer that one.
Yeah, most definitely. So if you hop onto NeuroEndocrine Cancer Australia's website, we, under our healthcare professional tab, we do have a NET specialist registry. So if your patients are wanting just to have a look and see if they're looking for a second opinion, or just wanting to get have a look at somewhere else, we do have a list of healthcare professionals there, whether they're oncologists, endocrinologists, surgeons. So we do have a list of specialists on our website that they can access and yourself.
Yeah, and just to let you know as well, that is not exhaustive. They're ones who have reached out to us to be listed, and we know that there's a lot of other excellent NET specialists out there of varying disciplines. So it's not the be all and end all if they're not going to whoever's on the list. We do reassure that I know in Australia it's very collaborative, and that any medical oncologist or other specialist who is looking after a NET will collaborate with the NET specialists around Australia. So they're not out there being cared for people necessarily who know nothing and not getting the right treatments. I've got another question here. Where's the best place to seek help if we get a complicated NET case, or just need just send some support with questions during the course of caring for patients? Any takers?
I can go. I think, reaching out to any of the organisations, NeuroEndocrine Cancer Australia, New Zealand and UK, we'd always be happy to have help and guide. We probably are more aware in our own domains or countries of the different specialists that might be available for people to approach. But just reach out and ask questions. There's lots of support out there within the neuroendocrine interested communities that would willingly take on questions from outside their areas as well if they need to. Yeah.
Mm-hmm. Another question is, how do we assist patients who are moving countries, like from New Zealand to Australia? Be either Kahlia or Avril that would be the responder of that one.
Avril, would you like to go?
Okay. Well, I guess if someone's moving to Australia from New Zealand, I'd be reaching out to Kahlia. Help Kahlia. They're moving to Sydney. Who is the best person for them to potentially get referred to? Or just trying to assist whoever's asking the patient or a nurse on the patient's behalf. So that's how I would be doing it.
And I have to say that when we've had it where people are sort of emigrating or immigrating across the world, that actually you guys have been really helpful. And I know we've had queries about people coming to UK, and the UK and Europe ENET's website has a list of all the specialist centres as well. So we've been able to share that. So yes, reach out and ask, and we do talk to each other. On NECA there is a list of all the patient organisations around the world, so wherever you're thinking of moving to, you can have a look, and it's broken down into areas of the world where you can find out who the best person to contact to maybe help signpost as well.
Great. This is just a technical question. Pro-BNP, which is a blood test, is that used in the UK or New Zealand for looking at cardiac function so that it might be an early indicator for carcinoid heart disease?
Yeah, in the UK, yes, we do use NT-proBNP as part of screening to look for any indication of carcinoid heart disease, and there are guidelines on the UKNet's website around what the cutoff levels are for further investigation. But obviously, that cutoff, you still need that clinical examination. Sometimes it can be borderline, but there may be physical clinical signs that would prompt further investigation. But yes, we do use it in the UK.
Mm-hmm.
In New Zealand, we probably don't use it routinely as a regular screening tool. We would use echocardiograms first, but it is coming in a bit more frequently with certain symptoms or criteria that patients might meet, and then the pro-BNP is being added potentially to monitor a certain group of patients within that.
Yeah. And I know with Australia, it's not actually on Medicare, so it's not rebatable for patients. So at the moment, there's a lot of clinicians who are pushing for that to actually be listed so that they can get a rebate to have it done, as opposed to having to have an echo, especially when they're remote patients and everything as well, that it can be a lot more difficult for them to access as far as echoes and travel and everything. So. So I just thought I'd like to get you each to describe what your organisation can provide with service provision to sort of our nurses who are listening here who might not be so aware. And I mean, it is something that's very common that most people don't know that we exist. So if you can promote what your service provides to patients and the healthcare community. Kahlia, do you want to go first?
Oh, I'd love to. So for healthcare professionals, as mentioned, we have our healthcare professional modules online that you can do. We have just trying to think, we have for healthcare professionals, we have, I've had a mental blank now.
Specialist support services. What does that include?
So for patients, we have our net nurse hotline, which patients can call from Monday to Friday. That is a free service that patients can access to reach out to their net nurses. We have a net nurse nearly in every state, but saying that all our net nurses can help on the line. But if there's something very specific to the state, yes, we do have most nurses in most states, which is fantastic to help. We also have a dietitian on our service who works every alternating Mondays and Fridays, and patients are able to access 3 free appointments with her. So the first initial appointment is 60 minutes, and then the 2 follow-up appointments are 30 minutes with her. And we also have a counsellor as well. So not only patients can access our counsellor, but also family members, children, young adults can access the counselling service. Again, it is free, unlimited consultations with our counsellor. And we also do patient forums in a couple of states a year, and we do a Living with NETs program. So we try to run 3 programs, I believe, a year, and it runs for 2 hours once a week for 4 weeks. And we have one coming up in October, actually. So that's really exciting. So we have lots of little things, and we also do support groups in most states. And if it's not in the state or you've got a patient that's more rural or remote, we do also do a national Zoom support group as well. And I'm sure we've got lots of other things there, but I'll leave that with you for them, and I'll pass it on to someone else.
Avril?
Gosh, it's hard when you're put on the spot like this.
Well, I sort of did pre-warn you, but
no, that's all good. In New Zealand, for nurses, we put on, it's kind of now combined. We used to have a nurse education day once a year in used to be historically in Auckland, but now, unfortunately, due to loss of sponsorship from the drug company that was sponsoring it, we just run an education day for our patients, and we invite nurses to come along and be there, because I think you do learn a lot even from those patient education days. So we run one of those every year, and we have started rotating it around different centres through New Zealand, because New Zealand's so little. We do one in Auckland, one in Christchurch, and one in Wellington, and that just rotates around every year. And next year we'll be in Auckland again. We also do, we have, our support email where nurses and patients can email through any questions that they've got, and it comes through to me, and I will try and answer those questions or offer some time back to those people, either by phone or by email, whatever works best, to try and answer those questions. We have also, through collaboration with NeuroEndocrine Cancer Australia, we've set up a Living with NETs program as well, which I run every probably 4 times a year, and it's 2 hours over 4 weeks as well. And it's mostly for patients that are quite new to neuroendocrine tumours, but we do get a lot of people who have maybe had their diagnosis for a number of years, and they come back and they want to join the course just to learn a little bit more when they're facing a new type of treatment that they haven't maybe been offered in the past. And we also have that health professionals access to that for our that course for health professionals. It's advertised as a GP module, but nurses can sign up as well. I can't think what else we've got. I think that'll cover it for the moment. Yeah. You can jump in there, Nikie.
No problem. And Nikie.
Thank you for going first. It's given me a bit of time to think. So for healthcare professionals on the website, we do have a dedicated page that will be being updated over the next few months to become a portal into a learning hub. And on there we have the Royal College of GPs modules that we've worked with them with, plus a link through to INCA's Think NENS programme. We have the RCN accredited competency framework as mentioned, and we are hoping to relaunch the academy as part of the Learning Hub in November, with the second phase coming through in April. We provide, as you highlighted in your talk, Kahlia, the overviews for different disciplines. In terms of information and other things, we have and support, we have the helpline, we have about 30 plus patient support groups around the country that's covering all 4 nations. Some of them are online, some of them are in person, and amongst those is a specific family and friends group. We run group therapy programs that twice a year. Those are living with neuroendocrine. There's one for the early years, and there's one for 3 years plus, and there's also a specific one for family and friends. We also do a mindfulness program. That's also run twice a year. We have a free to access counselling service. We do regular webinars. In fact, our next 2 months, this month and next month, are patient developed. So it's patient led. So devised by patients for patients, and our ambassadors put that together. We do have an annual patient event, which we try and make sure now is in, we rotate around the 4 nations. We have a welfare grant. We have the Ask, which is a contact form. So anybody with queries. We're involved in the Nets for Newcomers, which is part of UConnect's programme. We have a CNS group. We also have ad hoc learning programs. So we've gone into certain trusts and worked with the overall oncology nurse lead to give programs to their site-specific nurses. We have the patient virtual handbook, which is incredibly long, but is not meant to be read cover to cover, dipped in and out of, and that has podcasts and videos in amongst it. We do have a small little newly diagnosed booklet, a radioligand booklet, and access to the NECA info packs for those for whom English may not be their first language. And we worked with NECA to develop those info packs. And again, there's probably a lot more, like both of you guys said, but do visit the website and have a look. Don't be too overwhelmed. It's huge. Or just pick up the phone. You know, we're here to help.
Fabulous. Thank you. And I know, yes, each of the organisations have a lot more that, yeah, hasn't sprung to mind with me just sort of throwing that question to you impromptu. So thank you. There's one more question here. Are there Facebook or online groups for nurses that attend this session to share tips, support with each other? So I think to have a Facebook group potentially, or an online group of some description, so that it can be an easy access, so we can come back to everybody and who's attending this and ask the question if they'd like to, and we can set something up, because I think that would be extremely valuable ongoing as far as sharing information and just helping each other, so that NET patients collaboration is and care is so much more united across the globe. So
Most
everybody
definitely.
happy with that?
Yeah.
Yeah.
Lovely. Thanks, Sam. And I just want to thank everyone for those wonderful questions. It really made a great discussion. So thank you all. Again, we'll be sharing a survey link at the conclusion of this webinar, and we'd greatly appreciate if you could take a few moments just to provide your feedback when this does pop up, please. Yeah, let us know if you'd be really interested in having this online group for nurses. I think it'd be a great idea. I also want to let you know that we have another webinar coming up. So we're planning this for next year, hopefully sometime around March. So please keep your eye out for the registrations. We'd love to see you there. And finally, a big thank you to all the presenters and your time doing this. We really appreciate it. And for the patient reps for sharing their story. I want to also thank Alex from Crown 13. You cannot see him, but he is behind the scenes. He is our AV guy running things. So he's done a wonderful job tonight. So thank you, Alex. And thank you to Novartis again for sponsoring tonight's webinar. So that concludes our first Will Norman Nurse webinar. So thank you again for joining us, and I hope you have a wonderful day or evening wherever you are, and thank you again.
Thank you.